Hemophilia. Signs and symptoms. Defective or deficient coagulation, factors 8A and 9B. Potential complications. What can go wrong? Excessive bleeding. Injury to blood vessel results in bleeding and vessel constrictions, and clotting factors 8 and 9 are activated. When there's a lack of clotting factors 8 and 9, which weakens platelet plug, so incomplete fiber and mesh allows bleeding to continue. Who is at risk? Most common in men. Women carrying the recessive gene, female carriers will pass along to 50% of their sons, and 50% of their daughters will carry. Diagnostic labs, CBC, APTT, PT, fibrinogen test, factor assay, and X-ray. Monitor for the 5 Ps with compartment syndrome: pain, pallor, paresthesia, pulselessness or weak pulse, paralysis. Hemophilia. Prevent bleeding and wear a medical alert identification bracelet. Sub-Q route is preferred. When giving medication to prevent bleeding, avoid aspirin or any medication with aspirin. Acetaminophen is preferred pain medication. Stop bleeding ASAP. Administer the specific coagulation factor. Monitor signs and symptoms of hypersensitivity, hemothrombosis. Administer replacement factors and total rest. Manage any life-threatening complications. No contact sports. Health promotion. Acute care, ambulatory care. Outcomes. No signs and symptoms of bleeding, bruising, and patient able to state the needed knowledge and skill to manage their disease process. Genetic counseling. Due to hereditary nature and reproductive concerns of hemophilia, long-term effects. Medications. DDV, AP, IV, sub-Q, or intranasal. Factor 8. Advate, alphanate, alactate, hexate, FS, hemophil, M, humate P, coate DVI, cogenate, FS, monoglutamate P, Abazor for acquired A, recombinant exantha, factor 9, alpha-9, SD, alprolix, pepilone, VH Benefix, mono-9, profilenine, SD, Proplex T. Hemophilia. Compartment syndrome. Vasectomy, preventive care. Use of replacement therapy, gene therapy, counselor, genetic counseling, DNA testing, children limitations, prevention, and self-administration of AHF. Most common: hemophilia A, classic hemophilia, factor 8 deficiency. Hemophilia B, Christmas disease, factor 9 deficiency. Education of hemophilia, adaptation to the illness, provides psychosocial support, assistance, teach patient to recognize symptoms, wear gloves for household chores, ability to administer factor replacement at home. Look for signs for normal, mild, and severe. Symptoms can be mild to severe based on the amount of factor 8 or factor 9 in the blood. Almost normal lifespan due to improved prep of replacement products, improved screening of blood donor populations, and use of recombinant replacement factors. Monitor clinical manifestations. Slow, persistent, prolonged bleeding from a minor injury, several hours to days. Uncontrollable hemorrhage after dental extraction or irritation of the gingivale. Nosebleed. GI bleeding from ulcers and gastritis. Hematuria and potential renal failure from trauma or splenic rupture. Bruising, sub-Q, hematomas, compartment syndrome, neurological signs such as pain, anesthesia, and paralysis. Hemothrombosis, bleeding into the joints, deformity, damage, crippling. Normal CBC range, 150K to 400K millimeter cubed. Normal APTT, 8, 9, 11, and 12. Longer clotting time with A than with B. PT, 1, 2, 5, 7, 10. Normal with A and B. Fibrinogen, normal, 200 to 400 milligrams DL. Newborns, 125 to 300 mg DL. Substance abuse. Addictive behaviors. Addiction is a disease. The potential complications of substance abuse, psychiatric comorbidity, medical comorbidity, diabetes, hepatitis C, psoriasis. Who is at risk? Male, loneliness, depression, low self-esteem, family history of addiction, peer pressure, presence of mental illness, lack of family involvement, using highly addicted drugs, sociocultural children of alcoholics. Diagnostic labs that we'll be looking at are electrolytes. Prevention of alcohol withdrawal delirium is the goal. We don't want delirium. Screening tools, SBRIT, screening brief TACE, tolerance annoyance, cut down, eye opener, intervention, and referral to prescription audit. Alcohol use disorders ID test, CAGE, CAGE. 4 questions to identify alcohol abuse. CAGE aid. Same as CAGE, but adds drug use. Promote safety, participation in treatment, healthy coping skills, adequate nutrition, healthy self-esteem, client education, safety during withdrawal. Swaddling, demanding feeding, avoid waking, dim lighting, low noise level, pacifiers, breastfeeding, holding, cuddling, manual rocking, kangaroo care, water beds, music therapy, massage therapy, maternal participation. Medications when coming off a substance. Thiamine, Librium, Ativan, diazepam given to alcohol withdrawals, Narcan or naloxone, methadone, buprenorphine, opiate withdrawal. Interprofessional care, counselor, rehab. Background, neurobiological increased GABA, decreased dopamine. Environmental, poverty, peer pressure, sociocultural, alcohol not accepted or accepted. Discharge planning, psychotherapy, EEG, biofeedback, yoga, detoxification, rehab, halfway houses, partial hospitalization, outpatient treatment, Alcoholics Anonymous, relapse prevention. Addiction, primary chronic disease of the brain. Reward, motivation, memory, related circuitry, intoxication, excess use, tolerance, higher doses of same effects. Withdrawal stop symptoms can be mild to life-threatening and most likely can go back to the drug. So withdrawal, they may go back. Tolerance, they have high doses before they get what they want. Intoxication is when they have too much. Thyroid disease or Wernicke, acute reversible condition, or Korsakoff syndrome, chronic severe irreversible, and that one is wet brain. Signs and symptoms: alter gait, vestibular dysfunction, confusion, and several ocular motility abnormalities, horizontal nystagmus, lateral orbital palsy, and gaze palsy. Signs bilateral but not necessarily symmetrical, sluggish reaction to light, and anoscoria, unequal pupil size. Most patients with Korsakoff syndrome never fully recover. Methadone, liquid PO, given only by specifically clinics. Buprenorphine, sublingual tablet or film, Suboxone, can be prescribed by a primary doctor. Additional information. Impaired nurses. ANA Code of Ethics for nurse: poor performance, excuses neglect to patients. Maternal cocaine exposure, CNS stimulant, sympathetic decreases, blood oxygenation. Head growth may be one of the best predictors of long-term deficits. Irregular heart rate, lower language, motor and cognitive scores, and increased risk for learning disabilities. Notable to be seen at 3, 5, and 12 years of age. Increased SIDS and HIV, common in infants, signs and symptoms in the infant. Diarrhea, excessive suck, excessive feeding, hyperirritability, sleep deprivation or fragmentation, exaggerated motor reflex, infant diagnosis. Can be done by testing the urine, hair, or meconium. Alcohol is not accepted by Muslim majority countries. Afghanistan illegal citizens to purchase alcohol. Christian denominations as Pentecostal, Baptist, or Mormon. Alcohol, most common abused substance in the U.S. Alcoholism, primary and chronic diseases, pattern of dependence varies. Alcohol is absorbed in the mouth, stomach, digestive tract, and liver metabolizes 95%. Legal intoxication, 80 or 100 milligram per DL, or 0.08 to 0.1 Gs per DL. Withdrawal management, chlorodiazepam, tremulousness or agitation, lorazepam, or which is Librium, PO, I am tapered by 5 to 7 years. Withdrawal seizures. Diazepam IV, or PO, agitation, tremor, impeding or acute delirium. Opioid use, 80% heroin users. OUD signs and symptoms: intoxication, analgesia, euphoria, meiosis, constipation, sedation, itching, red eyes, histamine release, respiratory depression, and reduced cough reflex. Monitor aspiration. Decreased level of consciousness, hypertension, bradycardia, triad, coma, pinpoint, and respiratory depression. Dementia and Alzheimer's. Progressive loss of congenital function related to neuron damage or death. Affects the mood and affects encephalitis, meningitis, hypothyroidism, and drug-related dementia. Sundowners. Potential complications. There's no cure. Behavioral problems, altered sleep patterns, wandering, hoarding, resisting care, repetitiveness, delusions, hallucinations, agitation, aggression. UTI and pneumonia can increase dementia symptoms. They eat pocket food, potential tooth decay, prostate enlargement, rash, redness on skin, and breakdown. Who is at risk? Sex, family history, genetic factors, hypertension, hyperlipidemia, diabetes, midlife obesity, lifestyle risk factors, TBI, depression, sleep disorders, race, especially African American Hispanics, lower socioeconomic status, low education level, poor access to healthcare. Diagnostics and labs are CBC, EKG, serum glucose, creatinine, BUN, serum levels, vitamin B1, B6, B12, thyroid function tests, screenings for depression, nursing interventions for dementia and Alzheimer's. Changes of cognition, memory, behavior, alterations in mood, sleep patterns, ADLs. Never ask why questions. Determine a baseline for which to evaluate change over time. A mini-cog, which is a clock. And they can't put the numbers right. Mini mental state examination. Swallow precautions. Avoid trauma to the brain. Avoid harmful substances. Stay socially active. Take care of mental health. Treat diabetes, CVD, and sleep. Provide a diversion. Maybe it's art therapy, music therapy, healing touch, Reiki. Monitor chewing and swallowing, pureed food, thickening liquids, nutritional substances, easy grip utensils, finger foods, NG or PED feedings. Medications. ACE inhibitors improve cognitive function. Donepezil, rivastigmine, MMDA antagonists, Namenda, antidepressants, SSRI common is Prozac, Zoloft, fluoxetine, Celexa, and Trazodone for sleep. Antipsychotics manage behavioral problems and increase risk of death in older patients. You're not going to want to give them an antipsychotic. It will not help. Controlling undesirable behavior manifestations, providing support to the family. It's more important to provide support whenever the family member has dementia, because the ones that are affected more by it are the family members. Background information. 100 causes of dementia. Number 1 cause, Alzheimer's. It's 50% to 75%. Vascular, 20% to 30%. Lewy bodies, 10% to 25%. And frontotemporal lobe, 10% to 15%. When you're discharging, ensure safety, grooming, and hygiene needs. Utilize memory aids. For caregiver, reduce caregiver stress, maintain personal care, emotional and physical health, cope with long-term effects of caregiving. Provide end-of-life care. Promote quality of life and palliative care, not necessarily hospice. Modify goals, care plan as the disease progresses. 10 early signs and symptoms of Alzheimer's. Memory loss that disrupts daily life. Challenges in planning or solving problems. Difficulty completing familiar tasks at home, at work, or at leisure. Confusion with time or place. Trouble understanding visual images and spatial relationships. New problems with works and speaking or writing. Misplacing things and losing the ability to retrace steps. Decreased or poor judgment. Withdrawal from work or social activities. Changes in mood and personality. Stage 1. Can't remember names, loses objects, prefers familiar settings and people. Stage 2, forgets events of their own personal history, doesn't remember address, trouble controlling bladder or bowel, changes in sleep, appetite, wanders, behavior changes. Stage 3, needs 24/7 assistance, doesn't recognize family, difficulty talking, changes in ADLs, incontinent of bowel and bladder, prone to pneumonia and other infections. 3 stages of Alzheimer's. You have the mild, which is 2 to 4 years in duration. You have the moderate, which is 2 to 10 years of duration. And then you have the severe, which is 2 to 3 years of duration. Additional cognitive impairments. You got dysphagia, apraxia, visual agnosia, dysgraphia, inability to recognize people and friends, and wandering. Retrogenesis. Degeneration changes occur in the reverse order, which is acquired. Caregiver support respite care is needed for the caregiver. Ensure the family member that it's okay to take a break. Frequently can't remember the names of common objects. Appears more liable in label and mood personality. Decreased pleasure in previously enjoyable activities. Preclinical Alzheimer's dementia stage. Amyloid buildup can be detected with PET scans and CSF analysis. Mild cognitive impairment related to Alzheimer's dementia. Marked memory problems noticed. A measured ADL is okay, may or may not progress to AD. Dementia related to AD. Memory, thinking, and behavioral symptoms. Impaired ADLs. Terminal stage of AD encompasses mild, moderate, and severe. Once plaques and tangles have formed in the sufficient quantity, it may be too late to intervene to prevent disease or its progression. Sad, sad, sad. All right, delirium. State of temporary but acute mental confusion can be caused from severe chronic medical illnesses, medication, infection, surgery, drug or alcohol abuse leads to decreased awareness of environment or confused thinking. Usually a symptom of another disorder, neurological disorders. Pneumonia, urosepsis, age 65 or older, male gender, dementia, cognitive impairment, depression, history of delirium, use of physical restraints, pain, emotional stress, sleep deprivation, functional dependence, immobility, and history of falls. Who is at risk? Impairment of cerebral oxidative metabolism, multiple neurotransmitter abnormalities, cholinergic deficiency, excess release of dopamine, increase or decrease serotoninergic activity. Diagnostic and labs. Serum electrolytes, blood, urea, nitrogen level, creatinine level, complete blood count, drug and alcohol levels, EKG, urinalysis, liver and thyroid function tests, oxygen saturation level, lumbar puncture through the CSF, glucose, protein, and bacteria. Nursing interventions for delirium. Prevention, early recognition, treatment, and focus on eliminating precipitating factors. Protect patient from harm. Encourage family members to stay at bedside, and possible antibiotic therapy. Reorientation and behavioral interventions. Risk 4, immobility and skin breakdown. Involve family in care, emotional support, and know you can redirect a patient. Medications, Haldol, IM, IV, PO. Risperidone, signs and symptoms. Side effects: hypotension, extrapyramidal side effects, tardive dyskinesia, and atherosclerosis, muscle tone changes, and anticholinergic effects. Short-acting benzos, lorazepam, and Ptsd. Interprofessional care, you got the therapist, special, and psychiatrist. Background: serious medical illness such as bacterial meningitis causes delirium, altered level of consciousness, disorientation, agitation, emotional swings, hallucinations and delusions, restlessness. Discharge planning: patient will be free of confusion. Patient's cognitive status will return to baseline. Patient will perform ADLs. Most common cognitive problems in all adults are 3Ds: delirium, dementia, and depression. Medications can cause delirium: opiates like Demerol, benzos, and anticholinergic properties. Delirium is a risk factor for subsequent development of dementia linked to onset stress, surgery, sleep deprivation, pain, and depression, especially post-op in older patients. Causes: dementia, dehydration, electrolyte imbalances, emotional stress, lung, liver, heart, kidney, brain, infection, ICU, prescription drugs, injury, immobility, untreated pain, unfamiliar environment, and metabolic disorders. Lastly, can last 1 to 7 days, last for months or years, and sometimes don't completely recover. Sudden cognitive impairment, disorientation, clouded cerebrum, diagnosis complicated but inability to communicate medical history, psychologic history, physical examination, careful attention to medications, cognitive measures, confusion assessment method, CAM. Ptsd. Stressors, manifestations, signs, and symptoms. External influence: physical, mental, emotional, positive and negative, nightmares, night terrors, hallucinations, intrusive traumatic thoughts and memories. Re-experience or flashbacks of trauma, traumatic reenactments in play children. Self-injurious behaviors. Potential complications: panic attacks, phobias, OCD, physiological, cancer, COPD, diabetes, organ failure, myocardial infarction, acute and chronic pain, traumatic injury, psychological, birth of a child, caregiving, change in health status, death, diagnosis of a terminal illness, divorce, increased risk of chronic diseases. Who is at risk? Genetic, neurobiological, and polyvagal theory, vagal nerve number 10. Ventral, dorsal, psychological factors, attachment theory, environmental factors. Diagnostic and labs: physical exam, CBC, chemistry, profile, thyroid function test, urinalysis, urine drug screening or testing, primary care, PDS screen, severity, PDS symptom scale. Nursing interventions for PTSD. And this is the Ptsd syndrome beyond 1 month, re-experience, avoidance, and hyperarousal. Anyway, the nursing interventions is counseling, individual or group therapy, cognitive behavioral therapy, meditation, relaxation techniques, and massage. Time management, health education, consistently focus on the client's ideas, experiences, and feelings. Portray genuineness, empathy, and a positive regard toward the client. Emdr. Process traumatic memories through a specific 8-phase protocol: eye movements, audio tones, or tapping. Stage 1. Provides safety and stabilization. Stage 2. Reduce arousal and regulate emotion by symptom reduction. Stage 3. Catch up on a developmental and social skills. Develop a value system. Child. Establish trust and safety. Art, play, involve caretakers, educate grief process, social services. Medication. The most used one are SSRIs, like sertraline or Zoloft, Paxil, or MOIs, Vinzolene or SNRI, Effexor, TCAs, Remeron may be prescribed if SRIs or NRIs are not tolerated and do not work. Alpha-2 receptor agonists, quantity used for hyperarousal and intrusive symptoms. Alpha receptor antagonists, Prozosa, nightmares, sleep disturbances. Beta blockers, propranolol, hyperarousal, panic, trial, ecstasy. Bad part about all of them, these are all their blood pressure, so also the side effect would be hypotension. Interprofessional, counselors, psychiatrists, positive relationships, optimal health. Background info. Disturbed response to significant trauma, re-experience war, natural disasters, personal violence, symptoms. Nightmares to complete psychosis, avoidance, depression, substance abuse, decreases symptoms, alterations in mood. Discharge planning. Manage anxiety, increase self-esteem, improve ability to cope. Psychoeducation, psychopharmacology, CBT, EMDR. Eating disorders. We have anorexia and bulimia nervosa. Anorexia. The manifestations: fear and refusal to maintain weight, body image distorted, limit food consumption, excessive exercise, self-induced vomiting, avoid social eating, using diuretics, laxatives, diet pills. Amenorrhea occurs because they're refusing to eat and eat in presence of others. They cut food into small pieces while pretending to eat while they are around others. They're malnourished. A potential complication is malnourishment. Starvation, damage to brain, heart, and kidneys, heart rate, blood pressure decreases, irregular heart rhythms, heart failure, brittle bones, cognition decline. Highest mortality rate, complications of malnutrition, high rate of suicide, hair, nails become brittle, skin becomes dry, yellow, lingua on hairless areas, constantly feel cold. Who is at risk? Genetic factors. Major risk affect behavioral, neurobiological, temperamental variables, sociocultural factors, family as enabler, survivor, child or adolescent abuse, impaired conflict resolution, family-wide emphasis on achievement, performance, and after diagnosis. Diagnostic labs, physical exam, CMP, CBC, thyroid function test, EKG, albumin, total protein, bone density test, urinalysis, monitor INOs, electrolyte, monitor GI and cardiac function. Nursing intervention, prevention, reduce negative risk factors, body dissatisfaction, depression, self-esteem on appearance. Universal prevention, general public and target prevention, those showing symptoms. Anorexia nervosa, body dysmorphic disorder, life-threatening, intense fear of gaining weight, BMIs typically below 16. Monitor nutritional pattern and fluid intake. Assess ADLs, psychosocial history, patient's perception. Identify triggers. Patient will remain free from injury. Demonstrate manifestation of fluid volume balance. Demonstrate normal electrolyte levels. Not engage in purging behaviors. Actively participate in individual and or group therapy. Remain free of non-suicidal self-interest behaviors. Report any suicidal ideation. Adequate nutrition, reduce excess exercise, hospitalization in extreme cases, Promote a therapeutic relationship and positive self-regard. Medications that could help: SSRI, fluoxetine, helps after patient has reached a maintenance weight and aids in OCD behaviors. Non-pharmacological individual group, family-based psychotherapy, Maudsley approach with the parents, combination medical and psychotherapy. Interprofessional care, nutritionist, psychologist, psychiatrist, psychotherapy, acute care, nurse, and clinician. Background. Genetic neurotransmitter dysfunction, low levels of serotonin equals reduced satiety, increased consumption, high levels of serotonin increased satiety, decreased food intake, norepinephrine, norpeptide Y, increased food consumption, Dopamine inhibits eating. Endogenous opiates increase food intake, elevate mood. Cognitive behavioral theories, feeding and eating seen as learned patterns based on irrational thoughts. Beliefs, person's thought patterns equals destructive behavior patterns. Irrational thoughts are at the heart of the network of problems leading to feeding and eating disorders. Environmental factors. Discharge planning. Maudsley approach. Parents take responsibility for feeding the patient, especially the adolescent. Teach patient to decrease exposure to stress. Decrease anxiety by limiting caffeine, other stimulants, increase social. Teach methods of self-soothing and eliminate drugs. Alcohol due to increased impulsivity. Bulimia. Manifestations: onset late adolescent, early adulthood. Comorbidities: mood disorder, anxiety disorder, substance abuse, self-interest behavior, enlarged parotid glands, dental erosion and caries, menstrual irregularities, depressed mood, unexplained back pain, sore throat, toxicity from laxatives, lethal cardiac arrhythmias, low blood pressure, heart failure, electrolyte imbalances, bloating, slow peristalsis. Potential complications: tooth caries, ruptured vessels in the eyes, risk of metabolic acidosis, dehydration, impulsivity and compulsivity, chaotic, non-nurturing family relations, familial and our social instability, difficult interpersonal relationships, social isolation, electrolyte imbalance, increased pica in pregnancy, older adults, osteoporosis, GERD, cardiovascular problems. Who is at risk? Genetic factors, major risk, affect behavioral, neurobiological, temperamental variables, social, cultural factors, family factors. Family as an enabler, survivor of child adolescence abuse. Impaired conflict resolution, family-wide emphasis on achievement performance after diagnosis. Diagnostic labs: physical exam, CMP, CBC, thyroid function, EKG, albumin, total protein, bone density test, urinalysis, monitor INOs, electrolyte, monitor GI cardiac function. Protecting patient from physiological effects, identifying, treating, and causing, promoting wellness, encouraging healthy behaviors. Need to know the legal issues related to forced care. Monitor SS, GI, and cardiac function. Refeeding syndrome, metabolic disturbance that occurs as a result of reinstitution of nutrition in people that are starved or malnourished. Cardiac, pulmonary, neurologic. Monitor trips to the bathroom. Look for food hoarding. Outcomes: electrolytes within normal limits, positive body image, effective coping. Not linear process, but cyclic. Modified treatment PRN, which means you'll be doing well and then you'll have to start all over again. Again, the same as anorexia, fluoxetine is the only medication pre-approved, lessens binging and purging behaviors, reduces relapses. So usually they give fluoxetine for anorexia and bulimia. Nutritionist, psychologist, psychiatrist, psychotherapy, acute care nurse, dietitian, teamwork, safety, and medication. Background information: binging on food or overeating and vomiting or using laxatives to purge, obsession, excess exercise at least once a week over a 3-month period. Typical food or food of choice is junk food, fast foods, high calorie foods. Afterwards feel guilt, engages in purging, enemas, and diuretics. Discharge planning: cognitive behavioral therapy, CBT, individual group, find something they love, art, exercise, music, writing, etc. CAM, acupuncture, massage, yoga, meditation. So you can tell they're similar. Coping: anxiety, stress, and substance abuse. Manifestations: physiological: headaches, frequent infections, taut muscles, muscular twitches, fatigue, skin irritations, breathlessness. Cognitive: worrying, muddled thinking, impaired judgment, nightmares, indecisions, negativity, hasty decisions. Behavior: accident prone, loss of appetite, loss of sex drive, drinking more, insomnia, restlessness, smoking more, Emotions, loss of confidence, more fussy, irritability, depression, apathy, alienation, apprehension, alterations in sleep, eating, self-care, headaches, other pains, tachycardia, gastrointestinal problems, negative feelings, attitudes, mood swings, and frequent crying, poor judgment and lack of concentration. Potential complications: panic attacks, phobias, OCD, physiological cancer, COPD, diabetes, organ failure, myocardial infarction, acute chronic pain, traumatic injury, physiological, birth of child, caregiving change, and health status, death, diagnosis of terminal illness, divorce, increased risk of chronic diseases. Who is at risk? Women are at higher risk, greater than 18 years of age. Lower income Americans, young adults with children, Hispanics, impaired cognition, chronic health conditions, multiple significant life changes, socioeconomic status, caregiver, foreign country, language, cultural barriers, diagnostic labs, physical exam, CBC, chemistry, profile, thyroid function test, urinalysis, urine drug screen. Interventions, nursing interventions for coping anxiety, stress, and substance abuse. Individual perception, stress management and reduction techniques, coping strategies, action plan, therapeutic communication, interpersonal communication, public communication, small groups communication, minimize distractions, provide privacy, identify mutually agreed upon outcomes, set priorities according to the client's needs, collaborate with other healthcare professionals, counseling, individual or group therapy, cognitive behavioral therapy, meditation, relaxation techniques, and massage, time management, health education, consistently focus on clients' ideas, experiences, and feelings, portray genuineness, empathy, and a positive regard toward the client. Most common in children, separation anxiety, 8 months to 18 months. The medications given, usually for coping anxiety, stress, and substance abuse, are fluoxetine, lorazepam, thiamine, and Librium. Administer with medication and preferably at bedtime due to sedation. Interprofessional care, counselor, psychiatrist, positive relationships, optimal health. Background: stress is caused by an existing stress-causing factor or stressor. Ptsd, physical response, disease, lifespan response, physical response, Saley's general adaptation syndrome, or GAS, stage 1, alarm, stage 2, resistance, stage 3, exhaustion. Discharge therapy. Discharge planning. Therapy, educate how to utilize relaxation techniques and other anxiety reducing strategies. Educate the importance of taking medications as prescribed.